I think, Jeff, if you'd like to start, probably you can.
Okay, that's fine. Thank you, Paula. So yeah, we're at 42 people. I'm sure people will continue to join us. But thank you for joining, everybody. Thank you for making time on a Friday afternoon to join this, which is, I think, the fourth special interest group of the OMOP group. We have an agenda which I hope has been shared with you, and we'll start running through later. So I'm speaking to you as one of the chairs. So Jeff Hall, a medical oncologist in Leeds, and chairing this meeting in my role as the Chief Clinical Data Officer for HDR UK. So I've been asked to point out to you that we're recording this meeting for the purpose of taking minutes and just make sure that you're all happy that we do that. The team from the Alliance Group are going to make sure that we all behave ourselves, and in particular will mute people who are making more noise than we would rather, and we'll also monitor the chat for questions and try and help me see hands when I can't see them for whatever reason. Could I ask everybody please to use the mute function when they're not speaking to try and keep the noise down? But otherwise, let's dive on in. So what I will do is briefly introduce the first section and then hand over to Danny for very obvious reasons. And that is, today we're going to talk about the Real World Evidence Network. Now, the Real World Evidence Network is something that HDR UK have established recently. In April, a call was put out with some funding that had been ring-fenced to establish a coordination centre for a real-world evidence network that was going to use data from multiple sources across the UK, with a very clear plan and ambition to use that network to demonstrate the potential of the OMOP common data model, which this group has discussed on a number of occasions, as a way of making multi-centre and in particular multi-nation research studies much more efficient. HDR UK have done that because it very much aligns to the HDR UK central mission of accelerating the use of healthcare data to enable discoveries. And the funding was in many ways in two parts. The first of which was to fund the coordination centre, and the second was to recruit some OMOP-ready data partners. So that was an open funding call, and a number of applications were received. And I'm delighted to say that HDR UK have supported the bid submitted by Danny, Ed and Marty from Oxford. And therefore it is with a great pleasure that I'm going to hand over to Danny, both as a co-chair, but now as the lead of the HDR UK Real World Evidence Network. So Danny, with a fanfare of trumpets and overwhelming applause, thank you very much.
Thank you. Thank you so much, Geoff. Maybe you can applause after the presentation. See how it goes. Okay, let me share my screen. I have just 7 or 8 slides. I don't think it will take more than 10 minutes to tell you what we proposed and what was awarded. I'll start by saying a few words about our background and track records, because I appreciate that I think we have more of an international reputation than a national one. I think that's fair to say. We have been very heavily involved in the Eden project, which is a flagship European initiative to map data to OMOP, to create tools for OMOP analytics, and to basically collaborate with people from all over Europe, including many partners in the UK, to generate evidence from OMOP mapped real-world data. And we've been research coordinators there. We were leading one more package, and we also prioritize the data partners in there. So we have a lot of experience also engaging potential data partners. We do have also a lot of experience running analysis across federated networks because of our involvement in Darwin EU. Darwin EU is an initiative that you're going to hear about in a second, funded by the European Medicines Agency, to do loads of studies, hundreds of studies on the use, the safety, and the effectiveness of medicines and vaccines in Europe. We are also, although I hope only temporarily, the leads for the Odyssey UK National Note, which is an open science initiative, and hopefully everybody knows that there's an upcoming annual meeting in London in September on the Odyssey from Odyssey UK in collaboration with HDRA UK and the Alliance. And we have been involved also in loads of OMOP-based projects and initiatives that I don't have time to mention. The team that we have here and that I mentioned in the application is a multidisciplinary team, very experienced in the whole pipeline from mapping data to producing evidence. And we like to collaborate a lot to do scary things, hopefully without injuring anyone. This is from an activity, a team building activity that we did a couple of months ago when nobody got injured and everybody got smashed by somebody else's foot. This is our vision and mission, basically very much in line, I hope, with yours, which is to improve human health through the use of real-world data as much as we can and as far as wide as we can. And also that to reach that, we believe that we need to train people to increase capacity nationally and internationally and to improve the data and the methods that we use to generate real-world evidence. So this is how we planned our network. We want to build a pilot network of 7 data partners who have already mapped the data to OMOP, covering ideally different geographies and the devolved nations in the UK, across different healthcare settings from primary care all the way to very specialized care. And we are going to open a competitive call to partners who want to be part of this. And I really very much hope that you will find this attractive, as I think this will not only be an opportunity to get a little bit of funding, but also to collaborate, to build relationships, and to learn and teach, I guess, everything about your data and to make an impact also through a number of pilot studies. We're going to do pilot studies that we will co-design, hopefully with MHRA, NICE, UKHDRA, and colleagues from the NHS, and in collaboration with patients and citizens. And we hope that these studies will help us drive the development and test the network to the maximum of our abilities, but also at the same time produce data that can be actioned and be useful to improve already human health. As I mentioned already, capacity building is very important, and we will bake in training opportunities through training, bespoke training, but also through the participation and exposure to pipelines and analytics. And I think it's very important that we mention also that we are aware of challenges in the use of existing analytical tools that have been developed by international communities when we try to apply them in the UK settings, and we will be compiling evidence and information on what are the challenges and do we need to tweak existing tools or create new ones to make them available and feasible and usable within NHS and UK data partnerships. We divided the work in 3 work packages, 3 work groups. The first one is about data, is the data network, and the main tasks in there are going to be to onboard and characterize data partners, with very much an idea that by doing that we will help the data partners improve their data and improve their mappings and improve the richness and the quality of their data. We have another whole work package dedicated to the design, implementation, and the execution of the pilot studies that we will create. And then we have a work package that maybe is a little bit more boring, and I'm the one leading that, unfortunately, which is about sustainability. Maybe more boring, but very important that these pilots finds a way and a space to continue to exist in the future, and that we engage with stakeholders and plan ahead how this could work out in the future, so that this is not a one-off, but something that will continue to exist and serve the national stakeholders and the community. Just very briefly on the selection criteria that we proposed for the selection of data partners, because I really hope this will be a very competitive call given the number of colleagues in the UK who have access to beautiful data that has been mapped to OMOP. So we will take into account research readiness. That would mean, have you participated or do you have any experience running OMOP-based federated analytics? We will take into account governance. So we hope that people will be able to show that they can obtain approvals and that they have governance to do analysis on the data. And we will take into account also the technical infrastructure that you have available, so that we make sure that when we need to run analysis, those will run without too many technical challenges. And this we aim to assess using some benchmarking code, so some code that would run and generate just performance metrics. Also important, the size of the database or the data source that you have access to, including the number of people, records, but also not only the number, but also the richness in terms of number of rows as well as number of columns in your matrix. And then finally, coverage. As I said, we have the ambition to cover as much as possible of the UK geographies, healthcare settings, and we will, I think, give you a brownie point if you have additional data domains, like the oncology extension, or you have some additional data that maybe is unique or hard to find otherwise. Regarding pilot studies, as I said, we didn't propose anything too specific at this stage. We have a lot of things that we think are of interest, but our appetite very much is to co-design these with national stakeholders and patients and citizens. And the criteria that we will, or the principles that we will try to follow, will be impact, inclusivity, alignment with HDRA UK's driver programs, collaboration, novelty, and feasibility. So we want to hit a sweet spot on all those 6 criteria. And that's it from me. I think we do have time, Geoff, unless you disagree, to take some questions if people have any burning questions they want to ask. Otherwise, we can do that offline.
No, Danny, I think it would be good if we did take some questions now. So first of all, congratulations. I'm delighted that you have been appointed as the coordinating network, and I look forward to working with you to make sure that that is a success. I think we need the worked exemplars. I think there's a number of people that see the vision and the future, and at one level it's through the delivery of worked exemplars that we might convince the broader NHS to adopt this. So are there questions from people, or are there people who are interested to know? Do you know the timeline, Danny, on the call for data centers? Forgive me if you've already put that up there.
No, I think we'll make it public very soon, because we're working on the wording of that. And Alex and Paola are nodding. I think it's going to be from early July to late August. That, I think, is the I don't remember from the top of my head, I'm afraid, the exact dates, but it's going to be from early July to late August. We appreciate it's not a lot of time, but it's a 12-month pilot in total, and we're trying to give you 2 months out of the 12 just to put in an application. The application shouldn't be too onerous, to be honest. It should be relatively straightforward to fill in.
Danny, your slides talked around federated analysis of data. Much of Eden and the OMOP community internationally has done federated analysis through running common code on local data sets and then meta-analyzing the results, as opposed to, forgive me, what I would argue is true federation of these platforms that allow the analytic federating server to reach into the. Which is your vision?
Yes. So there are a number of reasons why we have gone that way, and most of them have to do with governance. So I have experience of having run federated analytics in the way you mentioned, which is basically accessing data directly and then having the ability to analyze it locally. The current governance is hard for that. I haven't seen any recent examples where people have been able to do that, unless it was on existing projects that had already been arranged some years ago. I think that at least my interpretation of the NHS guidelines on better, safer use of data for research would make that hard. There could be technical workarounds, I guess. There could be also methodological workarounds, like a statistical workaround to do that. But in my experience, all of the work that we are doing internationally as well as nationally is basically running in each data set separately and then compiling or meta-analyzing the results.
Okay, it would be good to talk offline about that because we've got some work underway with some centres across Europe where we're trying to do true federation. But I completely agree with you. The way to get this up and running and started is a single analytic code running against parallel data sets and a common data model.
Yeah.
And Jose has added a comment and talking about the work of DigiOne, which is absolutely the work I'm referring to, where we're using the Maastricht 6 the Vantage 6 platform from Maastricht to do that based on an OMOP dataset. So we could talk a bit more about that. Okay. Does anyone have any other questions or comments? Or Danny, if not, shall we move on to a number of more focused presentations, which Danny, could I come to you to ask to introduce?
Yes. I mean, you can also, if you have your questions later, you can ask me again later on, or you can email me. And thank you for that information, Jose. I'll look it up. Yeah, let me maybe then move to the next speaker. We have Ofer Al-Mosawi, who comes to us from GOSH, Great Ormond Street Hospital. And she's going to be telling us her experience participating in some of the studies using her data in the OMOP format. Ofer, do you want to add anything else about yourself that I don't know, maybe? No,
that's all good. Thank you so much, Danny. Thanks very much for the invite. I think my talk is going to be largely non-technical, and it's more of a wish list, but here goes. I hope it's okay. There we go. Right. Is this okay?
Yeah.
Great. Yes, so as Danny said, I'm currently a postdoc at Great Ormond Street Hospital, and I'm a research fellow at UCL. So at Great Ormond Street Hospital, we have something called the Children's Medicines Research and Innovation Centre, which we're trying to, which I sort of contribute to at the moment as well. So just a quick little bit of background about GOSH, and so sort of puts the OMOP data in perspective for me when I think about using OMOP. And I've only participated in OMOP studies once, so I'm a little bit of a novice, but you might want to hear novices' thoughts about this. So we're a specialist centre in London. Although we're situated in London, 50% of the admissions come from outside of London, so it's a unique patient population. We are partnered with UCL Institute of Child Health, and together we're the largest paediatric, or the only paediatric BRC in the UK, and we receive around 300 patient encounters every year, and we cover about 60 specialties. I think there are about 66 last count. We are also fortunate to have the DRIVE unit at GOSH, which is our Digital Research, Innovation and Virtual Environment unit. It's always a mouthful to say. So our unit, I think we have, it's pretty active. It does a huge amount. So if you want to look it up, you could go on their website. But all the data from the electronic health system that's generated at GOSH goes through our DRIVE unit, and that's pseudonymized for and made ready for use in research, and all this with pre-approved ethics. So we're able to assist, or the DRIVE unit are able to assist researchers at GOSH if they come up with a research question with pulling the data, and all we have to do is an application to our local R&D office. We have several partnerships with across the NHS and industry and academia. And some of the works that's been quite interesting that's been done via DRIVE is digital dashboards that facilitated a deeper look into data for, patient progress within intensive care units. My particular research interest is using real-world data in pediatrics, but everything I tend to focus on is all within the context of causal, so applied causal inference. I'm particularly interested in driving this methodology bench to bedside. So we have a lot of methods that have become available, produced by some great methodologists, but we're, as clinicians, not able to translate those immediately into practice. One particular example being causal machine learning, which I think was developed over 20 years ago, but the software is only just being developed at the moment, and the technique is just being developed. But in particular, I'm really keen on characterization studies, hence my interest in OMOP, because without those studies, I won't be able to then go and look at further detail. So I need to know disease characterization and drug utilization characterization in order to be able to design things. So that's where my interest in OMOP lies. And having real-world data for pediatrics, I would say, is absolutely crucial, because clinical trials, as you probably already know, are not very feasible. So I used to set up clinical trials in pediatrics for a number of years, and the recruitment was obviously slow. But to give you an example, we would work for 12 to 18 months on setting up one study, and then recruit about 2 patients, 3 if we're lucky. But that's the nature of pediatric studies. And because so it's really resource intensive, but then yield wise, it's small numbers. And because we are exclusively pediatrics, so nearly all of our studies are like this. And without collaborating with other centers, the numbers will always be small, even though for some rare diseases, we tend to have the most numbers at GOSH. And that data that we tend to use, so that makes us, because of the lack of these clinical trials and the lack of evidence for use of lots of drugs in clinical trials, we tend to use a lot of off-label and unlicensed drugs in pediatrics. And just to give you an idea of the scale of this, so 14% of medicines are licensed in children when they first reach the market, and it's only 6% in neonates. And that over the course of the following 10 years tends to increase to about 25%, but it's still a small number. In neonatal intensive care units, the situation's even worse. It's about 80% of all babies. And 50% of medicines have never been formally tested in children, yet we have no other choice but to use them. So because it's either that or nothing else. And 14% of these medicines that are untested, that are used outside of their license, have high quality evidence. And that's really what I think is really useful for us in terms of using real world data, because the fact that we have to use these medicines outside of their license, so the use does exist, which means that we can, if we design studies really well, achieve high quality evidence, but we haven't got there yet. And in addition to that, children are 3 times more likely than adults to experience harm from medicines. And the toxicity doesn't just relate to the actual drug ingredient itself, but also the other ingredients, such as the excipients, and the classic example being the alcohol content of a lot of drugs, which has been a huge issue in neonates. It's the equivalent of giving, I don't know how many vodka shots to a baby. So for me, I think at this time, even though observational research has been around for a while, but at this time, a lot of things have come all together at once. So these elements exist now in terms of having electronic health records in sufficient enough quantities that are quite large. We have long-term outcomes now through data linkage, whether the data are already linked, such as in Scotland and Wales, or we could actually, or the newer techniques that have been developed. So at UCL, the Child Health Informatics group that I'm part of, there are over 70 projects that have linked national data sets together. You've probably heard of one of them, the eChild dataset. And also we have methods that are in development that we could actually now apply to achieve that high quality evidence. So it's not, so we look at the associations at first, but then we drill further and try to mimic clinical trials to get some answers a bit quicker than clinical trials, because even if we do the clinical trials and we are successful, it sometimes takes years and years before these results are available to translate into children. So obviously the authorities, or not authorities, sounds like the police, our professional body, or our bodies are on the case. So the FDA are looking into using electronic health records, particularly in causal analysis, and that's in their Sentinel system to look at side effects of drugs. The UKHDRA also issued the statement well back in 2021, and obviously the European Health Agency through their Eden project. So naturally, I went looking for pediatric networks and pediatric groups within these organizations. So I looked at Eden, and the work package 3 talking about subpopulations particularly meant to me that there must be a pediatric subpopulation to look at, because personalized medicine is exactly what a pediatric population would need, with the differences in growth and development, and because one size doesn't fit all. But I could not find a pediatrically focused group, to be honest. So maybe correct me if I'm wrong, but I did try. I've been searching for a while. And I also looked at, and I didn't just search for this talk, by the way, I've been searching way before. Also from the Odyssey network, I found a couple of groups. The maternal and child health one has been archived, but the causal inference group is there. Not a huge bit of recent activity, but there were some pediatric focused groups, but not as part of a pediatric group. And that was, again, very focused in terms of biologics evaluation. So it was interesting, but again, it's not a big thing. So my experience in using OMOP was with Danny and the MHRA when they organized the study-a-thon in December. And we were looking at fluoroquinolones and the effect of the risk minimization measure that the MHRA put out to see what happens before and after, so drug utilization on a large scale. And then, as initially we started off as one study, but then we soon realized that we couldn't really lump children with adults when we're looking at this data. So we had to split into two groups and do the pediatrics analysis separate to the adult analysis. And that's because of the different indications that you're going to get, the different treatment effects that you're going to get, and the fact that we use them off-label. They probably won't even be used for the same indication or the dose. So, well, not so much fluoroquinolones, but other drugs. So what I was hoping we may have is OMOP for pediatrics. I don't know whether you want to call it OMOPOP or COMOP or something, but something that would be quite, not exclusive, but targeted at pediatrics and takes into account studies in children. Because whether it's clinical trials or real world data, we see that there's a huge underrepresentation of children in research. The next thing I had a look at to see where we could potentially start. So if you look at GOSH, we're the only mapped data partner from Europe that is exclusively children, but the hospitals in green are really large hospitals, and they have a huge sizable pediatric population. So there's a really good amount there, so we could start there by forming a group. Discover Now also serve I think all of Northwest London, and they have 2.5 million databases, and this is primary and secondary care, and they even have genomic data. They have quite a lot of different data sets. I still don't know how to access them, but I'm pretty sure they would have a lot of pediatric data in there as well. So the potential is there, just not sure how to go about it. Just to mention that there is one project which GOSH are participating, funded by the European Union, and that's the FEMS project, and that's bringing together multiple pediatric hospitals from across Europe to pool resources, but maybe that's another talk for another time. So for me, in terms of whether to carry out any research, where do I go? Do I use electronic health records versus OMOP? Then a starting point for me would be great to use, really, because the electronic health records are rich, they're granular. We have detailed data on both the prescribing and the administration of drugs. We are linked to the mortality data through NHS Spine, but we're still a single centre. We have an odd population in terms of who we see, and we don't have data linkage for long-term outcomes. So that's quite limiting. On the other hand, using OMOP gives us only aggregate data. We can capture the individuals, but not all the encounters. We get prescribing, but not administration data, but it does allow us to do international comparisons. And I said it can form the basis of our initial look at trends and characterization studies before we go deeper into other things. So I wondered whether it was possible to have, and my acronym is getting longer and longer, so a study-specific OMOP for pediatrics. So you could have the best of both worlds. Could it be possible maybe that we design a specific study in pediatrics with a ready-to-go protocol and then only map the data that we need for that particular study to the existing UK hospitals, so they don't have to do this mammoth task of OMOP in the entire hospital, but only focus on the study. So I don't know if this has been done before or not, or whether it's achievable. I'm sure it's achievable. Where there's a will, there's a way. But it needs to, I suppose, starts with a group. And final thoughts, as I said, children are very underrepresented in research, and we have a really strong motivation now, more than ever, to use real-world data in children, because we have a large amount of electronic health record data. And I think we need a pediatrics initiative in OMOP, and there's definitely an urgent need to develop high quality evidence for medicines use in children. I think that's it for me. Thank you very much.
Thank you so much, Efren. Just two quick reflections before I open for thoughts. I think there is no need to choose between EHR and OMOP, because EHR can be mapped to OMOP, and that's
exactly, yeah.
What we that's what we do regularly. The other reflection was I find it fascinating. I'm a GP by training. I'll say that first, because I think it's a kind of good context. I then trained as a rheumatologist, but my heart is, I think, very close still to primary care. And I find it fascinating when every time I talk about OMOP to people, their reaction tends to be, let's do a subversion of OMOP that basically will kill what OMOP is all about, which is about standardization, right? So the minute you de-standardize, you are departing from the whole idea of having a common data model and creating, a pediatric data model. That's
well, I think I sort of sold it wrong. I didn't mean to actually do a sub model, but more of a drive, probably, to go after pediatric data in a more of an organized way, and get a group to go and attack it together or something.
Yeah, and then as I said in the chat, there was an attempt to create a network of within Eden, and actually one of the people involved was from Gosh, so I can get you in touch with him.
Our fault then.
And we could try and revive that. Because there were 3 or 4 meetings and then nothing happened, which is a shame, because I entirely agree that it's an understudied population, and we all have been children before, and we all know children, so we probably all have an interest to make sure that we have better data to make decisions on that population. Is there any questions from the audience? Anyone else?
Sorry, yes, Alexandra. Sorry, I joined very late. Thank you, very interesting presentation. I'm really sorry I missed it, but there's always a recording. So what is the status of this? It's just a dream, so to speak, or you started?
Yes, it is.
already?
No, okay. It is my. I wish this was happening. So sorry that I misled you.
Okay, so it's no concrete plan. Thank you. But very interesting, and definitely you'll hear in my talk that we definitely need that. So
Thanks.
Let's see how we can bring it forward.
Jeff, do you want to go first?
Yeah. So, Afran, thanks. That was great, and I sort of completely understand your ambition, because pediatrics, if you like, is that slightly rarer subset of medicine, in the same way that cancer is, or perhaps triple negative breast cancer, where you actually need larger scale collaboration because of smaller patient numbers. So I can imagine that pediatric studies will absolutely need nationwide or even European or even international studies to get the numbers, and OMOP is absolutely the solution to that. I guess I was, first of all, you're absolutely right to point out Leeds Teaching Hospital has a large number of paediatric patients, and the OMOP work that we've done in Leeds didn't exclude any children. So we have large OMOP data sets on paediatric patients just because they got involved in the ETL process of our other OMOP transformations. So let's keep in touch, and I'm really happy to follow your leadership on OMOP-based projects. I guess I wanted to particularly make a comment that I completely agree with your plan to do study-specific OMOP conversion. I think people are highly intimidated by OMOP conversions when you talk to them about converting everything. And if you were to propose a project that, I don't know, looked at the age of ethnicity and social deprivation on acute admission to pediatric hospitals, you could run that study in many centres with about 6 data items.
Yeah.
And I think 6 data items is absolutely within the gift of almost every hospital IT department. And therefore, you would very quickly engage people into these large collaborative studies. Once you start getting into rare side effects of toxicity of uncommon drugs in intensive care units, then it becomes really, really hard.
Yeah.
So I'd encourage you to start small and broad and build the ground on which other studies will flourish. But, you know, it's great to have heard you talk, and I hope we can support you in your ambition.
Thank you very much.
David.
Yeah. Oh, sorry. Thank you. Yeah, really interesting presentation. Fantastic to see. I'm very keen to work out how we can support to move forward on the paediatrics for OMOP for paediatrics, or whichever way around that would go. And I guess how we also connect in with, because one of the things about particularly, I suppose, the specialist children's hospitals is they're quite good networks already, aren't there, across those?
Yeah, so like GOSH, we are already linked. We have an alliance with the other hospitals, but none of them are obviously mapped to OMOP.
Yeah, and then I think there's the sort of the international dimensions in there. But I'm wondering whether, again, there's more that we can do through the alliance and bringing in some of those specialist children hospitals, some of which are obviously embedded within large teaching trusts, but I guess there's still 3 or 4 ones that are sort of independent, to bring that sort of specialist angle together, and even just to sort of bring people together to think through what the sort of immediate next steps could be.
That
on that would be good. And obviously there's clearly regulator interest as well, which is always a good thing.
Yes.
Okay, I don't see any other hands up. Again, hopefully at the end we would have some time for further discussion. Otherwise, I'd be delighted to introduce you to Alex Pacurario. Alex is a colleague who works at the European Medicines Agency in the Data and Methods Task Force, and she's one of our counterparts in all the Darwin EU studies. I really like her vision on how we generate evidence at scale to inform regulatory decision making. Alex has also lived in the UK for a very long time before she moved to the Netherlands, and I'm really thankful that she found the time to join us today.
Thank you very much for having me. Do I share the slide? And for the very warm presentation, do I share the slide, or Alex, do you want to share them for me?
I will share the slides. Just a moment.
Super. Thank you very much. And yes, it's a pleasure to be here. I was a few minutes late, sorry, but I think it's a very interesting group for what we're doing, and I hope we'll collaborate in the future as well. So my talk will be on how real-world evidence is transforming regulatory decision-making. We are not the faster to adopt real-world evidence, but we are getting there. So, and I don't know, maybe I should have spoken a bit more about OMOP common data model, a bit more technical. This is not so technical. It's mostly about why we need it and a bit what we are doing already with it, just for inspiration, but maybe we can talk later. Next slide, please, then. Can I? No, you have to. I have to tell you, right? As disclaimer.
That's right.
Yeah, thank you. And the next slide. I don't have any conflict of interest. And the next one, thank you. So first I will present the needs, and then what are the options at the moment, and a bit of the common data model. So the use of real-world evidence in a regulatory application is fairly new. These are 3 papers that investigated the amount of real-world evidence in any regulatory application, 2 in Europe and the one on the right in US FDA. And you see the percentage depending on who you're asking, but it varies between 40% and 100%, quite optimistic, I would say. It's because the methods are very different. The time is not that different, but the methods, for example, the one on the left includes non-published information because it's done in-house by one of our colleagues. The other ones include only published information. And what does real-world evidence mean? And also what does it mean it contributes? So they use different definitions, and then they came up with these results. But bottom line is that the therapeutic areas that are more likely to benefit is always the same: oncology, anti-infectives, hematology, the top 3, but not the only ones. And the key message is that it's mostly included to support safety, a bit less efficacy. It can be found in all phases and across all different therapeutic areas. So, and even 40%, which is the pessimistic or the more smallest number, it's still quite enough to warrant a lot of attention. So next slide, please. So this is, yeah, we also think that real-world evidence can be used across the entire product life cycle. You're probably very familiar with post-authorization and safety, and still this is more likely to benefit, and it's our bread and butter because it's very easy, it's easier to do safety research with real-world data. Then we have the marketing authorization application, where it's usually very hard because, as you can imagine, the standards are very high. There are a lot of clinical trials. I mean, that's the core business and the core evidence generated still, and it's rightly so. And it's, of course, it's much less room to complement, but there is still some. But also the pre-authorization. So the companies are in touch with regulators way before the evaluation. For example, if they want an orphan designation for their drug, if they want scientific advice, how they should develop, what type of study are likely to succeed, well, to succeed passing the authorization, and if they want to apply for a pediatric investigation plan. So, and I think in this area, we were surprised that the demand was higher than we expected. Next slide, please. So these are the type of study. We group them in three categories. So what do regulators want to know? They want to know if a study that the company did is representative or valid. They want to know if it's feasible to plan a study, because sometimes the companies say, well, we don't have enough patients, and they want to double check that. To understand the clinical context, for example, disease epidemiology and clinical management. Here, an example would be if a drug is the first in class or second in class, and you want to understand how patients are treated in real world. I mean, not according to the guidance, because sometimes it doesn't happen 100% according to the guidance, or you want to see the uptake of a very newly approved drug, and the academic, the publication are not always like, you rarely see a study in the last 6 months that didn't end 1 year before, at least. And when we're talking about drugs which are recently approved, 1 year, 6 months of extra data makes a huge difference. And the last but not least is, of course, the safety and the impact of regulatory action. So very often we want to see if we took a regulatory action to withdraw a product or to restrict his indication in a way, and we want to see if it's working. So that's a very important part. Next slide, please. And these are actually what actually happened in the first 18 months of DAO in EU. So you see that still safety is our, as I said, bread and butter, the most used category. Then we also have design and feasibility of applicant studies. What I was telling you about, is the sample enough? Are the companies right telling that they can't find enough pediatric patient with a rare disease, or we can do something about it? Drug utilization and clinical management, and also disease epidemiology. So updates on incident prevalence of disease or overall survival in a type of cancer. Maybe they have data, but it's from 5 years ago and in only one country, and they want something more generalized at European level. Next slide, please. So this is actually what happened. And these are also what happened already. So what we did in the first 18 months, research topics by committee. We have 7 committees and a lot of working parties. I won't bore you with the acronyms, but the first committee is, again, the safety committee, PRAC, post-marketing safety, authorization safety, and the second one is the pediatric committee. So as I said, it was very interesting to see that they have a huge demand, need in terms of real world evidence. And the third one is the orphan committee. And why we see this, that they have this huge demand, is because precisely they deal with rare diseases or rare diseases in a special population, children, and then the numbers get smaller and smaller and smaller, and we need these multinational, multi-database study, which at the company level are very hard to do. If you don't have a system, if you don't have a federated network, it quickly becomes very expensive, prohibitive, even doing a clinical trial, because then you need a hospital that run a clinical trial, they have 3 patients, and then you need 10 more hospitals, and so on and so forth. So we see this, and we're trying to support them. Next slide, please. So what can we do now? What can we access? Next slide. So the traditional route was that regulators were passively exposed to real-world evidence that came from marketing authorization or from academia or national competent authorities, so whatever was in the published domain. But now we have the opportunity to generate real-world evidence in-house, as to speak, or from us, coming from the regulators, for the regulators. And we have 3 pathways in Europe. One is in-house study. So we have a team at TMAs that can perform studies. it's a very it's kept very quickly by the human resources because we don't have a lot of people, and by the amount of data we own, because as you can imagine, it's very expensive and very hard to procure and own a data source. So now we have only 2 currently. The framework contract, so we can externalize a study to a contractor like happens in the commercial world, but of course, because we're a public organization, that has to be always transparent, and we have to reopen the competition every time. So we can't go to our dedicated, if we like someone to work with someone, we can't go to that specific. Of course, it has to be all reopening of a competition, and that means we have 2 awards, so it takes a long time. And the third one is DarwinU, which we hope to scale up a lot. I mean, it's already scaling up a lot, the generation of real-world evidence. And next slide. That's what I will talk mainly about. So DarwinU is a federated network of data, expertise, and services. And what we do differently from the rest of the world, although it's not a unique initiative, it's unique in the sense that it's designed for and with regulators. So we are both the requester, but also the actors. So we are very involved in that via EMA, but also via the data permit authorities. So some national competent authority participate with the data. So the data stays local, and that helps a lot with access to the data. We will see it later on. And we use the OMOP common data model to perform study, and that increase both speed and size and also interpretation of results. Next slide, please. So we are now in the 3rd year of DarwinEU after 2 establishment years, and we are working on standard analytical pipelines and code to reuse, to be able to reuse the code and save time. We onboard data partners as we speak. We currently have 20 data partners, and we hope to have 60 studies only this year, so per year, 60 studies per year. Next slide, please. So these are our data partners. We have 20 so far. It's a mix of hospital data sources, GP practices, claims data, a little bit less because it's not so popular in Europe, but we do have them. And also, what else do we have? We have biobanks from Estonia and from UK. And I think that's it. And of course, linked primary with secondary data care, which we like a lot. So it's quite diverse. Initially, we focus on the large data sources, on the best one, on the one which were advanced, already using the OMOP for a long time. And now we are also using onboarding a bit more specialized data sources like cancer registry, and yeah, so on and so forth. And we are also looking in pediatric specialized databases. Next slide, please. So it's already quite big, and what makes it work is a common data model, which is basically a standardized database structure. And in case of OMOP, it's also standardized content, so the same vocabulary that allows this analyze of multiple data sources concurrently. And I like this image that it's overused, I think, but it's still a very nice one with sockets in different parts of the world that once you standardize, they all become similar. And I put here a quote that the analytic goes to the data instead of the data to analytic, because that also helps protect the patient privacy and ease the data access hugely. So the fact that the data is a patient level data does not need to travel from its own server hospital, for example. Next slide, please. And yeah, this is structure of the common data model. It can facilitate access by allowing data to be analyzed in its own environment. As I said, the data is not leaving its place, its server. It increased tremendously in speed, both by the fact that everything is standardized, but also by allowing to use standardized analytics across all data sources. But not only, for example, the phenotyping, which means creating this definition of a disease is much easier if you don't have to do it in 7 dictionaries, because Italy has one and Netherlands has one and UK has one, and that was the case before, and I can tell you it takes a long time, and it also can increase the errors. Translation is not perfect. I mean, translation is not perfect anyway, even if you standardize, but that's another discussion. It increases in size as more data partners can participate, because now we all speak the same language, and it's easier to compare and interpret results, because also the variables mean the same thing. So yeah, it's much easier to interpret when we're talking about the same concepts. Next slide, please. So these are, speaking of standardized analytics, so these is the second thing that help us, of course, in combination with the OMOP, because it wouldn't be possible without the common data model to have standardized analytics. It facilitates and it increases speed tremendously of studies. So basically we have some buckets of studies that are predefined, pre-coded, and whenever the study research comes in, study question comes in, we adapt those to the study question. But that's in theory, it should require only minimal adaptation. So far, because we are in the establishment years, the adaptation was more than Danny would like, at least, but also than our likes. But we are fine-tuning, and hopefully it will be less and less fine-tuning needed. But yeah, the idea is that we don't code from scratch and we don't start from scratch. We have some standard analytic, and that increases the speed enormously in the network. And yeah, what we do here, it's mostly incidence prevalence, either of diseases or of utilization of medicines. We do patient characterization, drug utilization, and descriptive epidemiology, so natural history of disease, as you would call it. Next slide, please. These are examples of recently completed studies. So we see a lot of drug utilization. We see multiple myeloma, again, rare diseases. We work a lot. We have a lot of questions on rare diseases. What else? Drug utilization of medicine with prokinetic properties in children, treatment of lupus on the right side, also in children. So you see already a predominance of oncology, of rare diseases, and of diseases in children that are, yeah, this what the requests come from. Next slide, please. Yes, so after 2 years, we already saw that the federated network can deliver real-world evidence for medicine regulation. The time taken for study varies per study. I don't have exact timing now. I think we are scratching the number now, but I can tell you already that it's between a few months and a year, which is already much better than a study done in academia or in a CRO, or even by the study that companies are doing when they're imposed by regulators. And that takes, I think, even I never seen one in a year even. So that's already very good. We need to further map the data in some studies. So we are talking before about the study-specific data model and the database general common data model. We work with the whole data source map, but this entire data source is not exactly the entire data source, because especially for the new data partners that converted their data, some things are harder to convert than others, and they decide to deprioritize them. For example, a classic example is ICU. I think someone mentioned that. So ICU it's because it's complicated to map. It's usually deprioritized, and because there are not so many studies in ICU, but we needed at some point ICU data, and then we went back to the data partner, and they map specifically this piece which was missing. So I think that's the beauty of it, that sometimes you can do partial mapping, but you can enrich without needing to start from scratch. You just add extra layers on top. We need to work more on the standardized analytical pipelines, because we are adapting to the request, and there is always a bit of fine-tuning needed. I think we can benefit from more automatization, but it's always a balance, because we're working with requesters who don't care so much about standardization. They just care about the research question to be answered. So yeah, we need to find the balance. We have an excellent stakeholder engagement so far and interest to use real-world evidence. And I want to thank to the coordination center team and all the investigators and ECDC and all the requesters for the study. I think I have a few more, if you can, one more with the number of study. No, this is with the highlights. Yes, if you want to know more, a few websites, so the Darwin website and also the page we have at EMA about Darwin. And also you can contact the coordination center for any questions you might have. Thank you very much. Yeah, this was with the study. So yeah, thank you.
Thank you, Alex. Yeah, I think that this is a beautiful example of the tension we always encounter with OMOP of, mapping only a little bit of data, but then every time you have to do a study quickly, you need to map additional data, or mapping everyone and everything at once initially, and then not having to do the work anymore. In my learnings, and I guess reacting to the comments from Ofran and Job and now Alex, I think it's an iterative process, right? So we need to see what's the best option for every different use case, and then reach a a point where we feel happy that we have mapped enough data to answer commonly and quickly. And again, it's all about, thinking ahead and saying, well, if we're going to be doing a lot of incidence and prevalence, we need to map the data to calculate that. But maybe for other things, we don't need to map everything. So it's interesting to hear different use cases and perspectives, I guess. Thank you so much, Alex. Is there any question or any comment from anyone? Paola, I think, on first.
Thanks. Just a very quick one, and just to say thank you, Alex, for the presentation. It's the first time we have the EMA as well, so brilliant to have you here today. A quick one on the involvement of industry, or what you think the involvement should be, because there's quite a lot of expertise out there in terms of OMOP mapping and also capabilities, training, and skills. And I think I've noticed that one of the data partners as well in the network was IQVIA database, maybe in Belgium. So I just wanted to understand what's the involvement, and how do you think we should or we could collaborate more with industry?
Yes. Well, it's if you say IQVIA, that's not really industry, it's a CRO, but yes, they can contribute with data if they own data, and that's what IQVIA does because it has a large amount of data, and with principal investigators. They are subcontractors, but as users, the pharma industry is not yet allowed to use a Darwin network. I personally hope this will change and we'll find a way to collaborate, but of course we need to, the idea is to generate evidence independent for regulators, and we try to keep that. But I'm sure there is a way we can make it work at some point, but we're not there yet. We start to build step by step. What is happening now is that the industry is allowed to comment on some Darwin deliverables. They commented on the standard catalog of standard analytics, so their input was taken into account, and they also comment on studies. If we have complex study which are product specific, we contact the specific company and we ask them for comment. Yeah, they're allowed to comment. Yeah.
Thank you.
But yeah, we hope the involvement will increase over time. Yeah.
Thanks.
David.
Thanks, Alex. I'd say really interesting, and thank you for coming along, taking the time to talk to us. There were two things I'd got. One was the scale of the funding that's going into this program, and any indication as to sort of where that sort of funding goes, if you've got that to hand. And I guess the second question then is how you're sort of, I think through the sort of portfolio of data partners and almost like the lessons you've learned from the ones you've got to date, and how sort of go about filling those gaps.
Yes, interesting questions. The funding, I'm not an expert, but I can tell you it's public funded so far, and that's why we are not involving industry. So it's very independent in terms of funding, and also we are very careful with the data partners, so they are not funded by pharma industry. With regards to the data, I don't know any more details, but maybe if Danny wants to add something. In terms with the data partners, yes, a lot of lesson learned. Do you mean more where the gaps in data are, or what, if you're the data partner, what you may encounter as an issue? Or
I was thinking more about the sort of, in some ways it's sort of not quite chance, but there's an element of chance, isn't there, as to who has chosen to can transform their data into OMOP, and you're almost like, it feels like, I'm certainly we're thinking, you're sort of trying to make the best of what's already out there, but as you use that, you then identify where there are gaps both in, I suppose, variables that you then need to have mapped, but actually where you might have just total sort of coverage issues, and how to sort of think through the portfolio of the data.
Okay, yeah, I understand your question now. So, well, yes, of course. So our condition, especially in the beginning, was that the data is OMOPed. Now we are a bit more relaxed. We're saying, are you willing to convert into OMOP in a acceptable time frame? So they don't have to be converted. I mean, they have to be onboarded, but we are still exploring. So if we find a very good data source that is not converted, we are usually having a dialogue with them. But if they say we're not interested, or we don't have any resource, and we won't have any resource in the next 2 years, of course we don't onboard them. In terms of gaps, well, we would like to see more primary to secondary link data sources. We would like to see more cancer registry. There is a lot of, the data sources are not talking to each other, so usually we onboard a cancer registry, and it's impossible or very hard to link with the GP or with a normal hospital to know what the patient had before the cancer, so to construct a medical history. The medication is an issue, usually is not mapped. it's a lot of work to map the medication completely and nicely with duration and so on. And that's, especially for the new data partner, this is an issue over and over again. So medication, yeah, and again size, because of course we onboard data partner by data partner, and then yeah, would be better to have a hospital lake or something. So for them to pull the data before they get OMOPed, but that's another story. Yeah.
Maybe Alex, if I can add two quick learnings that I think are useful for the UK context, David. One is some countries like Finland, for example, have decided to go into a mode where they have an institution centralizing the collaboration with the data partners, which is facilitating our work quite a lot. Because basically there's one place to go, right? One phone to call, if you like. And that wasn't like that in the past. And I think it's a very good initiative. And then the other one is that we are encountering now that the data partners that we use all the time, because they are very good, tend to then get a little bit overloaded with work because people didn't plan to do 100 studies like Alex wants to do per year. They probably plan to do 20, you know, and even if you give them some money, we don't live in a world where you just want a data scientist trained in OMOP and you get it like that, right? You need to train people and it takes time. So I think there's also that kind of bottleneck that I couldn't really predict initially, although probably was it, you know, predictable to some degree. And then infrastructure, right? So those same data partners sometimes are overwhelmed if they have to, you know, do lots of analysis at the same time, and that is causing delays that are not really related to, you know, we can now write protocols and reports very quickly and run federated analytics very quickly, but sometimes people have 10 things running at the same time, and then that takes a bit longer. And, you know, this kind of scalability of the infrastructure, although I'm not an expert in that, is proving also quite an interesting bottleneck sometimes. Any other questions from anyone or any comments? Thank you so much, Alex. I think that was fantastic and
Thank you very much.
Very illustrative of a very impactful initiative that's using OMOP internationally. Geoff, I'll pass it back to you if you want to go for the next.
Okay, that's fine. Thank you. And our final talk is by Cahinda. Are you with us?
Yes, I'm
Cahinda,
here.
hello there. Thank you for joining us.
You're welcome.
And delighted that you're able to come and talk to us. And the floor is yours to talk about the mapping landscape in your area.
All right, thanks so much, Geoff. My name is Cahinda Adinayi. I'm a business analyst working within the NHS Research SD network. I work within the Tech and Data Community of Practice Working Group. Yeah. The presentation today is basically around the overview of the survey. We conducted a survey across the NHS Research SD network to understand the OMOP mapping position and the direction of travel on OMOP mapping across the SDs. Could you move to the next slide, please? Thank you. All right. Yeah, the government strategy paper, Data Saves Lives, reference the secure data environment, SDEs. The SDEs enable the secure access to NHS data for researchers from a secure workspace. That is moving largely away from data sharing to secure data access for the researchers. In England, we have 12 NHS SDEs, 11 subnational SDEs, and NHS England SDE. The SD is premised on the 5 Saves framework, which define the principles underpinning the design, the implementation, and the operations of the SDs. I'm certain that we are very conversant with the principles of safe data, safe projects, safe people, safe settings, and safe outputs. Could you move to the next slide, please? Like I mentioned earlier, we conducted a survey. The Technology and Data Working Group of the Data for Research and Development Program conducted an OMOP mapping survey in between February and March this year. And the purpose of the survey was to understand which of the SDEs have undertaken OMOP mapping, the data sets that they have converted to OMOP, the use cases driving OMOP mapping, the tools that supported the OMOP mapping exercise. And we also wanted to know if they have published their mapping and the barriers to OMOP mapping. Yeah, so could you move to the next slide? Thanks. All right, so we got responses from all the SDs, that is the 12 SDs. 4 of the SDs have undertaken OMOP mapping of some of their data sets. 5 out of the 12 subnational SDs responded that they've not undertaken any OMOP mapping. And we had 4 that responded that they are in the process of undertaking OMOP mapping. If you can see the responses here, these are 13 responses because we got 2 responses from a particular SDE that conducted OMOP mapping in the past and are also undertaking OMOP mapping. I need to put a caveat here. These are responses as at March 2024, so we could have moved, there could have been some movement with some of the status around OMOP mapping. Yeah, could you move to the next slide, please? Yeah, so it was important to understand the drivers for OMOP mapping across the SDE network. So we posed a question to understand what are the drivers for OMOP mapping. As you can see in the responses here, the major driver for OMOP mapping is making data accessible for cohort discovery. And the second, very closely to that, is based on research or researcher requests. Yeah, could you move to the next slide? All right, so this is a very high-level summary of the outcome of this survey. Examples of some of the data sets that have been mapped to OMOP CDM across the SDE network include reporting data sets, radiotherapy data sets, myeloma, I hope I pronounced that correctly, maternity data sets, cancer data set, just to mention a few. Then when we asked them some of the tools that they've used that supported the OMOP mapping exercise, the responses include DBT, Data Build Tool, Azure Databricks, SQL, Python, Carrot Mapper, Usagi, and the like. I hope I got Usagi. So the use cases, like I mentioned earlier, was around cohort mapping, cohort discovery rather, and meeting research or researcher requests. When asked if the SDEs have published their OMOP mapping, 2 of the SDEs mentioned that they already published their OMOP mapping, with 4 more planning to do so. There was a question around barriers to OMOP mapping, particularly because we had some of the SDEs that have not performed any OMOP mapping conversion. So they said issues around vocabulary mapping, some concerns around time and resource constraints concerning around OMOP mapping, understanding difficulty in understanding the source and target structures, then limited publicly available mappings. Then there was also some responses around the financial implications of having to undertake OMOP mapping. Yeah, thank you. I think that's all. Yeah, thank you so much. Any questions or comments?
Kehinde, thank you so much. It's really good to see that